the organizers, policy circle, I think the Nair couple, and everybody else on the team, and of course Mr. Akhtar Khan, who I think is doing a beautiful job this morning. Uh, I think the last two speakers emphasized something very crucial that I'm going to come to, and what's been alluded to, the need to help those who are already addicted, and need for treatment services in addition to awareness. But before I come to that, let me begin, if you'll permit, with a bit of a journey over the last 40 years that will bring to the points that I want to make, only the key points that I want to make. It was in the 1980s, after my psychiatry qualification at NIMANS on the faculty, that we started working on alcohol drug abuse treatment prevention programs. And I realized individually that tobacco did not figure in the list of alcohol and drug abuse treatment prevention programs. Nobody bothered about tobacco. I was somehow interested in what is happening in the West about tobacco prevention and treatment. And allow me to also recall 87 World Conference on Tobacco and Health, world or global, I think World Conference on Tobacco and Health. The then DG WHO headquarters, Havden Meder, in his inaugural said, and I'm almost quoting, I can't be sure if the exact quote, but paraphrase that. He said the smoking rates have already started coming down in the West, and the countries of the third world better beware, next few decades the market is going to attack you. And I was so struck by what DG WHO said at that World Congress, and that seems to have happened in the last few decades, especially about women, addressing women, addressing youngsters. So there is the issue of market that I don't think I heard since the morning at all. The entire marketing industry and what happened in the US with tobacco industry. As part of my public health training at Hopkins, which was the fulcrum for bringing out all these skeletons out of the tobacco companies' files, I've learned a lot about that. And please be sure, what we are discussing since the morning is a very complex issue of human behavior that we psychiatrists and mental health professionals claim to understand. I don't think we do. We claim to understand, we try and study it. But there is the whole issue of market that we can't overlook. Come back to my recap. In the 1990s on the AIMS faculty that Dr. Khilani and some of us were together, Mishra Saab and us, I began to see again as part of the Drug Abuse Treatment Center of AIMS, which became the National Center later, I began to come across, I began to come across colleagues, faculty colleagues, their family members, junior and senior residents who had tobacco dependence, and there was no treatment available. In the 90s, of course, there was only the non-specific use of benzodiazepines or counseling, some behavioral techniques, and fluoxetine, if you could use as a craving suppressant. Fortunately, around the turn of the century, a lot of treatment methods have become available. Psychological, behavioral, and pharmacological. And so 2001 is when we, in that corner in Shadra, the Institute of Human Behavior and Life Sciences, you'll be happy to know, we started the first tobacco cessation clinic at IBAS in 2001. And 2002 is when the WHO country office came up with what is now a big network. There is actually, ma'am, a big network of tobacco cessation clinic, government funded as well as in the private sector across the country, across states. So if you come across people, especially in the lower strata, who require treatment, please be sure, look up TCC, refer to them. TCC networks are available. Come back to the larger issues of regulation, tobacco control. The other thing I want to avoid by now, is this controversy about vaping and the ban. Dr. Khilnani is a very respected colleague, so is Srinath Reddy, and that committee that they must have. But I'm not for total ban on vape. I'll make my position clear about that. Bijon and we have been on many platforms together, mainly on the issue of evidence being inconclusive. Second, consumer rights. Consumer rights not just for the client, but also for the provider. If I, as a treatment provider for tobacco cessation, if I don't have the spectrum of things to offer, that's a bit of a problem. And I think Basin Saab made such an exquisite, eloquent thing about the legal constitution aspects of that. Just a few summary points to, as I've understood in the last 40 years, having delved into this a lot. Like Dr. Mishra sir, my colleague said, Please understand, there have been over the last at least 56 years, post-World War, more than earlier, science effort at modifying group behavior, especially when it comes to personal health behavior. And the one thing that has succeeded is risk to the others, what is called in insurance terms passive risk. And I learned in the 80s and 90s that in health terms, it also got translated to passive risk. Allow me to recap this quickly. 1964, the Surgeon General of US came with irrefutable evidence that bronchogenic carcinoma was linked to smoking. Irrefutable. Nothing happened for 20 years. It was 1984 JAMA that the first robust evidence on passive smoking came up. And then things changed immediately. So what happened in the 80s and 90s, please recall for those of us who lived through that or those who might have studied, if young colleagues, it's the issue of you may do whatever you like, don't risk my health. Smokers' rights versus non-smokers' rights. HIV, same. So there are two areas where we have succeeded, please understand. Now here is the major point. The areas where we have not succeeded. Alcohol, illegal drugs. Because there is no passive risk involved. Except for one small niche, if you want to understand, campaigns against drunken driving succeed because there is again the element of passive risk. You can't drink and drive and endanger my life or safety. But drinking in general, alcohol prevention doesn't work through passive smoking. Passive risk, right? So what we'll have to realize is, like everybody has said in the morning, regulation, some amount of regulation, laws, but social awareness mainly about my right versus your right. What seems to work is only that. And that has worked very well, reasonably well, except for these dangers of market. You see, like it was said for tobacco, and I think Adar was trying to ask you jocularly, see, once I have a factory and I'm producing something, if you reduce the consumption in this area, what do I do? Like Havdan Mallar said in 87, I turn my marketing strategy here. If it doesn't work in this room, I turn it somewhere else. So how are we going to counter the marketing strategy vis-a-vis, human behavior tendencies, which can never be completely controlled when it comes to personal behavior? Let's face it. I'm repeating myself. The only major principle that works in modifying or regulating or controlling personal human behavior about health is the idea of passive risk. That's the only thing that has worked in the field of health behavior. Everything else has very limited area. I will say one more time that treatment has been like chewing has been a blind spot relatively. I'm happy about the fact that a lot of people since the morning here have at least spoken about what I think has been a huge blind spot. And to that, we have no solution, especially because there is no concept of passive risk involved. Will you ever be able to come up with something about oral chewed tobacco that can say you can't chew because you're affecting my health? Unlikely. And so, unfortunately, because of socio-cultural issues, marketing issues, and this aspect of personal behavior, we are on the brink of a major epidemic of chewed tobacco problems, not so much the smoking. So let's stop aping the West about smoking issues. I'll stop there. Thank you so much.
Wow.